With that, it gives me great pleasure to introduce my co-moderators on the stage today. And they're Dr. Laura Olivieri, who is a national expert in three-dimensional imaging, including CT and MRI. And we had the pleasure, she joined us from Washington, D.C. for the past year, and she's been quite amazing. She's the director of non-invasive cardiac imaging at the Heart Institute at Children's Hospital, Pittsburgh, and associate professor of pediatrics. Thanks, Dr. Olivieri. And with me, there's also Dr. Julie Filippi, who is the Ronald Pellegrini Endowed Chair and Associate Professor of Cardiothoracic Surgery. She's also the Vice Chair for Cardiac Research and Scientific Director for Cardiac Surgery Research. And she works in the lab exploring the role of vasa vasorum in cardiopulmonary disease. Thank you both for joining us. And with that, let me introduce our next speaker, who is Dr. Rachel Torok. She is the director of the Pediatric Aortopathy Program at Children's Hospital of Pittsburgh and assistant professor of pediatrics. She's going to be talking to us about screening for aortic disease and family-centered clinic. Thank you, Dr. Torok.
Thank you, Arvind. That was an excellent presentation. I'm really excited to speak to you today about pediatrics perspectives on aortic screening and our family-centered care at our clinic at Children's Hospital of Pittsburgh. All right. So breaking down our objectives, we'll review the screening process in children for aortopathy and connective tissue disease. And given the time constraints, we'll focus a bit on Marfan syndrome. We'll explore the importance and pertinent points of family-centered care and highlight the huge amount of collaboration among subspecialties that's involved in providing the best care for our families. While thoracic aortic aneurysms are often associated with lifestyle factors in adults, such as hypertension and hyperlipidemia, in kids, it's typically related to a genetic syndrome, with Marfan syndrome being the most common cause. And so that's why we'll focus today on Marfan syndrome. But certainly we see other cases in our clinic, certainly Loeys-Dietz families, children with vascular Ehlers-Danlos syndrome, and other syndromes. So as a pediatric cardiologist who specializes in aortopathy, there's about 6 main ways that patients make it into my clinic. And oftentimes it's referred by our genetics team, so they're either undergoing a connective tissue disease evaluation or have confirmed connective tissue disease associated with aortopathy. There can be a family history of connective tissue disease with aortopathy, so Arvind may be seeing a parent and will send the children to my clinic. There could be a family history of aortic aneurysm. Ophthalmology could see a child with ectopia lentis and refer to my clinic. That could just be an incidental finding on imaging where there's a dilated aorta. But I'd say far and away the most common cause is that the child has a Marfanoid body habitus. So they're a long, lean patient and somebody has raised the question of Marfan or other connective tissue disease. Marfan syndrome affects 3 main systems of the body, the musculoskeletal system, the eyes, and the cardiovascular system. And of course, the risk of aortic dilation and dissection are the main causes of morbidity and mortality. And with this high risk of aortic complications in patients with Marfan syndrome, we need an effective screening process to identify patients with Marfan syndrome. So we use the revised 2010 Ghent criteria to calculate a systemic score. It's based primarily on physical features. The score is out of 20 points, and a score of 7 or greater is considered concerning for Marfan syndrome, not diagnostic in isolation. So we'll go through the features of the systemic score, and I'll highlight a couple of pitfalls as we go along of things that could be a little bit tricky. So first up is looking at the thumb and wrist sign, and oftentimes parents are following along with me as we're doing the systemic score in clinic. So the thumb sign is shown here, where the adducted thumb protrudes beyond the ulnar part of the palm. And if it's the entire distal phalanx, not just the tip of the thumb, then it's considered positive, and I think sometimes that's overcalled. The wrist sign is where the thumb and pinky are brought around the wrist, and if the thumb is able to cover the entire fingernail of the 5th finger, so covers the pinky fingernail, that's considered positive. It's not just the thumb and the pinky touching. If both of those are found together, that's a huge deal. That gives you 3 points. So I think it's really important to be kind of stringent with looking at those features. If just one or the other, wrist or thumb sign are positive, that's 1 point. Other features that give points at two points is pectus carinatum, or outbowing of the breastbone. That's considered a little more specific for Marfan syndrome, and so that's 2 points, whereas pectus excavatum, where the breastbone is bowed in, or if there's significant chest asymmetry, that's just 1 point. Next is the hindfoot deformity, shown here, and so that needs to be taken into account as well, where there's a true valgus deformity of the ankle when you're looking behind. Versus pes planus, there's not a true valgus deformity. The foot is just flat. So hindfoot deformity is 2 points, and pes planus would just be 1. In the middle is protusio acetabuli. That's a rather rare finding that I see in my clinic. It's based on an X-ray finding where the acetabulum is beyond 3 millimeters beyond this radiographic line here, the collar line. And then spontaneous pneumothorax or dural each would be 2 points as well. Some less specific but still important features we look out for are looking at the arm span to height ratio, and a cutoff of greater than 1.05 is considered positive. But in addition to having that being abnormal, you also need to have a reduced upper segment to lower segment ratio, meaning that you have rather long legs as well. And the age of the patient in pediatrics is taken into account. There's different cutoffs for pediatric patients, as well as ethnicity differences. So if both of those measurements are abnormal, you get a point. If it's just one, you take it into consideration, but you don't actually get a point in your systemic score. Myopia is a point if it's worse than 3 diopters. And then there's facial features of Marfan syndrome that we take into account as well. And so dolichocephaly, or kind of a lengthened dimension from anterior to posterior on the head, malar hypoplasia, where there's less prominent cheekbones, anophthalmos, or deeply set eyes, retrognathia, or a small chin, and downward slanting palpebral fissures are all the features that we look at, and you have to have 3 out of 5 of those features to get a point in the systemic score. Next is mitral valve prolapse by echo, as we typically diagnose it. And then there's reduced elbow extension. If the angle between the upper and lower arm is 170 degrees or less, that's considered reduced extension. That's a point. And then scoliosis as well. And it has to be significant scoliosis. So when you bend forward on Adams forward bend test, if there's a 1.5 centimeter difference between the left and right ribs, that's considered positive. Or on x-ray, a Cobb angle of 20 degrees or greater is considered positive. Finally, stria, ones that aren't associated with weight changes or with pregnancy and are typically in a little more atypical location, so on the mid or lower back, would also give 1 point for the systemic score. And so one final plea that a positive systemic score in isolation does not equal Marfan syndrome. I need to know more beyond that. So just meeting a systemic score does not equal Marfan syndrome. I need to know what the echo looks like. Is there a dilated aorta? Is there mitral valve prolapse? And is there an FBN1 mutation that's pathogenic? What's the eye exam like? Is there ectopia lentis? And then what's the family history? And so all of these things need to be taken into account before the diagnosis of Marfan syndrome can be made. So without a family history of Marfan syndrome, if you have aortic dilatation and a positive systemic score, that does equal Marfan syndrome. If there's aortic dilatation and a pathogenic FBN1 mutation and ectopia lentis, or dilated aorta and ectopia lentis, that's also Marfan syndrome, or ectopia lentis is a pathogenic FBN1 mutation. So 4 different ways here without a pathogenic mutation, without a family history. Next, if there is a family history of Marfan syndrome, if there's a positive systemic score or ectopia lentis or dilated aorta, that all equals Marfan syndrome. So those are all the pathways to get the diagnosis. All right. And so if there's a new diagnosis of Marfan syndrome, it's a busy first clinic visit, and sometimes it has to be scattered among 2 visits to get all the information in and to not overwhelm the child and the family and the care team. And so we spend some time discussing the echocardiogram findings, make sure that the patient's established with our ophthalmology colleagues and are having at least yearly visits with special attention to the retina and the lens. For patients, we're certainly screening for orthopedic issues. If there's significant scoliosis or other concerns like hindfoot deformity, then making sure they're plugged in with orthopedics. If they're having significant joint pain or having difficulty completing their writing work in school, then maybe they need to be plugged in with physical therapy. Medication management, as Arvind discussed, is something that we need to address at this visit. Activity restrictions, probably one of the worst parts of my job as a pediatric cardiologist is saying what they can't do, but again, we do try to emphasize what they can. And then making sure the family is receiving the best care and the genetic testing has been appropriately done to help catch any patients who also may be affected in the family. And so genetic testing for FBN1 mutations identifies about 80% of patients with Marfan syndrome. It's an autosomal dominant disease, and about 25% of cases are de novo. And we work very closely with our genetics colleagues to complete the genetic testing both for our patient and for their family members. Oftentimes we have a genetic counselor that's available with us in clinic to make sure that we can complete the genetic testing for our pediatric patient and then help see any of the adult patients in the family who also need genetic testing. So just Jessica Sebastian is the genetic counselor who works closely with her, and we're very grateful for the care that she helps us provide. If an FBN1 mutation is identified in the child I'm caring for, then I proceed with targeted parental testing. So I look for that same pathogenic mutation in the parents. If the parents are negative, then you don't necessarily have to test the siblings, though some institutions still do. There's a rare risk that there could be gonadomosaicism, where the gamete itself had a mutation that affected progeny, where the parent wasn't actually affected. If the parent is positive, then certainly all siblings and first-degree relatives for that parent need to be tested. And so let's kind of walk through a case here. If I have a child here who has a pathogenic FBN1 mutation, then I look up and test the parents, and I identified the father here was affected as well. So then we looked at a sibling, not affected. We looked at the parent for my child's father, so the paternal grandfather, who actually was affected. And then we need to look at siblings of the father of my patient. So 2 of the siblings are affected, and one of those siblings has children, and those 2 children are affected too. And I think this just highlights how appropriate family screening in just one pediatric patient can make a huge impact in a family. So one patient here led to 6 other family members being diagnosed and potentially could prevent, a life-threatening complication. Other things that we consider during our family-centered care is making sure that when we have identified an affected parent, that they're taking care of themselves. I think we typically do our best for our kids. I think that's why I am a pediatrician, is that we, parents will do their best for their kids. They'll get them to the appointments. They'll make sure they're on their medications, but they're not always so good about taking care of themselves. And so when I'm seeing a patient and I know the parent's affected, I do always ask, are you up to date on your imaging? Are you taking your medicines? And you'd be surprised how often they're kind of slumping in their chair and saying, well, not so much. And so if that's the case, we make sure that we've offered them a referral to our adult congenital heart disease team if they're not already established with them, especially in some of our patients who have rare disease like Loeys-Dietz syndrome or vascular EDS. Sometimes they say, like, my team doesn't even have any other patients like me. They're not familiar with this disease. Why even bother going? And I think it's so helpful to say, hey, I've got a team for you, and that same team is going to take care of your kid down the line when they're older too. It just makes a difference knowing that this family has a medical home and will be taken care of as they progress into the adulthood years. I typically see patients up until about age 25, but we start talking about transitioning to the adult congenital heart disease team between that 18 to 25 year period, depending on the patient preference. All right, next. So up until now, we've talked about pretty straightforward cases where we had the diagnosis, and we're able to confirm with genetic testing. But unfortunately, we often live in shades of gray, and so not everyone is clear and upfront on their presentation of exactly what they may have. So there may be cases where it's a young child. Features of connective tissue disease develop over time, and so they may just not be showing their features of connective tissue disease that need to be followed. And so if there is a borderline systemic score, like a positive 4, 5, 6, then certainly I obtain an echocardiogram, make sure that the aorta looks okay. If the echo is reassuring, then I typically will follow them up in about 2 years to repeat the connective tissue disease exam and repeat imaging. And we typically will do that until late adolescence or early adulthood. If they're truly borderline and they still haven't, shown their true colors, then they may even need follow-up through adulthood, though maybe we can space out follow-ups. If the aorta is dilated on these borderline patients, then we have more of a discussion about should we pursue genetic testing or not, and I'll leave that to later discussion today. All right. So to wrap up, then, just aortopathy in children is typically due to a genetic condition, with Marfan syndrome being most common. The features of connective tissue disease develop over time, and so children who have borderline features need to be followed longitudinally. And finally, family-centered care and testing is imperative to ensure that we provide the best care for our patients and their loved ones. And that takes a huge team. Pediatric cardiology, adult congenital heart disease, adult cardiology, CT surgery, ophthalmology, orthopedics, genetics. It's a huge team, but I think we've been able to provide a really great care for families. All right, and with that, I'll wrap up. Thank you very much.